All good? Okay. All right, good afternoon, everyone. I hope that you have enjoyed your day, and thank you so much for the opportunity to come to present to you a bit of our perspective. So my name is Daniel, and this is Tory, and we're going to be talking to you today about collaborating within OSCAR. So first, I'd like to get a better understanding of who is all in the audience. Hands up if you are clinicians, office managers, or the like. How many of you, with your hands still up, please, collaborate with other healthcare professionals through your OSCAR? So half or so. Of those people who do collaborate, what sort of folks do you collaborate with?
Pharmacists and nurses.
Pharmacists, nurses? Pharmacists? Mental health counselors? All right. So we've got a whole host of different healthcare professionals. So what we hope to get through today is to give you a bit of our experience of working with pharmacists in the primary care networks and what collaboration looks like between pharmacists and prescribers. First, we'll start off just with a land acknowledgement that we respectfully and gratefully acknowledge that UBC Robson Square is located on the traditional, ancestral, and unceded territories of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. We have no disclosures to disclose outside of we're paid by UBC and primarily through the Ministry of Health. To give you a better sense of who we are and sort of our roles within the Pharmacists and Primary Care Network program, I'm a quality care pharmacist, so I work directly with our pharmacists who are in these primary care networks and helping them support their clinical practice in terms of their day-to-day practice, documentation, relationships, referral processes, and I'll hand it over to Tory.
Okay. Am I actually working? Yeah, it is. And I'm Tory Kim. I'm the program lead for the Pharmacist and PCN program. So I lead kind of the clinical and the administrative end. I kind of swoop in if there's something going on in a PCN where someone needs some support from our leadership team. And we've both been involved in that for about the last year and a half or so. Okay. Today we wanted to just talk to you about how the pharmacists in the program have been leveraging the functions of EMRs, including OSCAR, to facilitate team-based care, and also share our learnings about perceived barriers and solutions that may be there from our experiences in shared EMR charting. So first of all, what is the Pharmacist and PCN program? It was perfect to come after Lawrence's talk and talking about PCN. So I know a lot of you are part of a primary care network, and there are more and more being formed in the province. So UBC has been leading the first 3 years of implementation of the Pharmacist and PCN program. And what this means is that in each of the PCNs, there's pharmacists that are supporting the providers there and working together with other allied health members to support your practices. Our aim is up to 50 pharmacists in the first 3 years. We're going to be in the mid-40s, I think, by the end of this first 3 years, just because there's some areas that have been really hard to hire in where there's no pharmacists in those areas to hire. While UBC will only be leading for the first 3 years, the program will be ongoing, and so you'll hear more probably in the next few months about how that leadership will look and how it will be designed in the future. And we primarily focus on adult patients with complex medical needs. So we're not looking at a patient who needs just some basic counseling that they could get, popping in for 2 minutes to their community pharmacist. Really more patients who need to have a chance to sit down for half an hour, and really get through their medications. And we're obviously very aligned with team-based care principles and trying to work together with the whole healthcare team. So when you think about, there's many types of teams. Some of you have worked long enough that you were in a solo practice. You didn't have any nurse, any allied health of any sort helping you. But primarily now we see more collaboration between either physicians or nurse practitioners and nurses, or sometimes physician or nurse practitioner, nurse, and pharmacist. Those are probably the most common that we see. Highly multidisciplinary teams, sometimes you see within like a UPCC or a primary care clinic, or you see that obviously at the hospital and ICU where you've got your whole team coming together, and sometimes specialized teams. When you look at an MD or RN-centered team, often, there's not really a referral system. You just like kind of say to your colleague that you're sitting there working with, hey, you want to come in and see this patient with me, or can you see this patient before me? It's very casual and very easy, right? And then when you have the physician, pharmacist, and nurse that really work together well, that can also often happen. Or there may be a referral within OSCAR, which Dan will talk about a little bit later. And then in a multidisciplinary team, or really in an interdisciplinary team, you actually will often come together and create solutions together. So if you've had like a care conference for a complex patient, you can work together and figure out solutions together. The way we've sometimes see like in a hub situation, so sometimes some of our pharmacists who aren't co-located in clinics and just get referrals from a hub, it's really treated a little bit more like when you're sending a referral to a specialist. And it's good, but it can sometimes lose a little bit of that interoperability of being able to be in an EMR together and share that information. And we'll talk a little bit later about information, and it really goes to what Lawrence was saying too about there's sometimes all this information, you're not sharing it, and when you don't, then we don't learn from each other, right? So really, we've mostly seen those teams that are either we're integrated or we're kind of off to the side. We're going to talk initially really about EMR access, which is sort of the first step to being able to work together in EMR. And then Dan will speak further on referrals and how we use EMR, including OSCAR, to coordinate care. So EMR access, if you look at the literature, there's not a ton of literature specific to pharmacists having EMR access. However, there are some studies that showed, there's many studies that show working together with a pharmacist in primary care will improve outcomes. One such study talked about using similar case finding, which we've heard about a couple times today, of looking at how many of your patients have hypertension with a blood pressure, a systolic above 160 or whatever. Like there was one particular study that looked at blood pressures, certain systolic and certain diastolic pressures, and having the pharmacist meet with those patients, try to get the patients to target, et cetera, charting in the EMR, making sure that the provider is aware of everything that's going on, and really showed a huge improvement in blood pressures. So without that access, it's again where we have that siloed information. You're saving information for yourself that someone else doesn't have. And so the same thing happens if you don't have PharmaNet access. If you don't have PharmaNet access and no one tells you that your patient doesn't actually fill those medications that you order for them, then you're missing a huge piece of the pie, right? So really that information sharing is super important. The other thing is thinking like, oh yeah, they are in the circle care, but I'm scared that they're going to look at my information. So it's interesting when you look at the information that's out there from FBGC. I can never remember the acronym for it. But the information that's out there on what is appropriate to share on an EMR, and really it's patients that a provider is seeing, or it could be even for case finding, right? So it could be that they're saying, well, I'd like to help you with your patients with diabetes, and so I will do some case finding to help support that. So the privacy concerns, we'll talk again about what team charting agreements really briefly. And then also sometimes people are like, well, if they look at my EMR and they're going to see I'm doing a terrible job. Well, just because your patients all have a high A1C doesn't mean you haven't done your job. If you've been meeting with the patients, asking them to do things, and your patients have a difficult time with managing their A1C, then it's not necessarily your fault, right? So really nobody's out on a fault-finding mission. Everybody's out to really look at how can we help support you in your practices. One of the things with thinking about EMR access is we recognize that patients are the owners of their health information, right? And so having them to understand that the people that will access an EMR are people that will be helping with their care is really important. You can use EMRs to also do quality improvement, like it was perfect timing again after Lawrence's talk, and also a way to identify referrals. So when I worked in a primary care clinic for about 10 years, we had certain screening tools we'd run certain reports for certain patients to try to make sure that we caught those patients, like high INRs or low GFRs, et cetera, or screen through patients that a nurse practitioner or physician was seeing in the near future. You know, there's different ways to look for patients that would make sense for a pharmacist to see. And you guys may or may not be familiar with team charting agreement. So if you have a healthcare provider that is not part of your team, that's part of, say, for example, the health authority, and is coming into your practice, then there's these things called team charting agreements, which there's guidance and a sample agreement that you can use. Sometimes for particular health authorities, they may have a special agreement. There is some trickiness if you're in Vancouver Coastal Health with pharmacists, because they're actually considered Fraser Health employees, because we're all one big happy family in Lower Mainland Pharmacy Services, but it just means an extra form. But your PCN can help you walk through that and get those forms signed so that it's all legal. Really, again, trying to everyone chart in one place is obviously the best way. Sometimes I know that's not always possible. You know, it may, with OSCAR, it's much more possible, which is great because you aren't going to pay $600 a month for an extra user. So certainly we would encourage you guys to open up your EMRs to pharmacists so that you can work directly with them when you have a clinical pharmacist that's working with you. Also, I think the nice thing about a team charting agreement is it delineates the roles and responsibilities of each person in using that EMR. There's, I think, a sample poster on the FPSC website that you can put up in your clinic to say there are people, and it could be pharmacists, it could be dietitians, it could be the nurse, who are employees of a health authority that is accessing your patient information, and that just keeps it legal. Again, we have a link to the template from FPSC. I think that's it for me. I'm gonna.
Yeah. So we've sort of gone through the first milestone. You have said, I'm interested in perhaps having a pharmacist involved in the team, and you now have given them access to your version of OSCAR and your instance of OSCAR. So they now have access to patient information. So now it comes to the point of, well, who is the pharmacist actually going to see? How are they going to get involved in the care of your patients? And we have sort of two major routes to sort of go through this. And I guess really first to highlight that the EMR's access really reduces that need for a really thorough consultation request note. So you now no longer have to have several pages of information that sort of helps summarize the referral to the pharmacist or to get them up to speed. They have access to your EMR. They can look up that information. You can just simply write in, please see this patient, A1C and blood pressure is uncontrolled, or this patient, new diagnosis of heart failure, recently discharged from hospital, send. Now it's in the pharmacist's court to be able to gather the information because they already have access to it. So the two ways that we can go about, or two main ways that we have found of being able to generate referrals or identifying who should see a pharmacist is the prescriber-initiated referrals. These typically are patients who are top of mind, the most complex, not perhaps 100% sure what would be the next best choice for a particular disease state. This is the people who end up getting referred to us by prescribers. So lots of different ways that this can happen. Within a PCN, if there's a form that's required, well, you can create an e-form and you can simply fax that through the consultation module. But if your pharmacist has access to your OSCAR, you can send them an inbox message. You can send them a tickler. Again, trying to really eliminate those barriers to referring to a pharmacist. The other way to do it is having a pharmacist identify who may benefit from being seen by them. And this is described as case finding. So we can use the reporting function or report by template within OSCAR. Depending on the variables that you want to use, you can use single or multiple variables. That again depends on the quality of the data that you have within your EMR. Not always perhaps in the right spot to be able to be pulled by reports. So the other way that we have gone about this is through billing codes. Billing codes are probably a little bit more, I guess, accurate. So you can identify those patients who are perhaps would be more likely to benefit from being seen by a pharmacist. Patients with heart failure, COPD, maybe they don't have a recent action plan, asthma, hypertension, diabetes. There's different ways to go about it, and Some of those are perhaps less sensitive and less specific than others, but these are different ways that we can access or identify patients who would benefit from a pharmacist service. From our experience, those pharmacists who are co-located, so actually within the prescriber's office, we have found that the way that we generate the most referrals is simply by that inbox message or by a tickler. This really sort of, again, really helps eliminate the need for a long referral note. It can be very quick. It can be very, very quick, very responsive, and the pharmacist can then go and manage the scheduling themselves of how or when they're going to be able to see that patient within your clinic. Alternatively, if the pharmacist is more perhaps in a hub model, you're able to refer into a pharmacist's services, then we're likely going to see more fax referrals using plus or minus e-forms to help facilitate some of that. There can be, again, if the pharmacist has access to your EMR, then they can go and read the background information. So less information that's required for the initial consult. And then the other way, again, as we described, the case finding from the pharmacist perspective of either having sort of more data-driven by reporting, report by template, or billing code-driven. And again, this is a huge plug for PSP and getting them involved in your practice, as this really does help facilitate that extra layer that you have to think about as the prescriber. Oh, should I refer this patient to the pharmacist? Maybe the pharmacist is in once a month in your clinic and you haven't seen them for a couple of weeks, so that's out of your mind. The pharmacist can then work through that depending on the data that you have. So we have the pharmacist who has access to your patients. You have now identified patients who want to be seen or that you think would benefit from being seen by a pharmacist. Now it comes to the part, well, they're now involved in the care of that patient. So how do we coordinate that care? And so this really comes down to messaging and charting. Where are the notes that the pharmacist creates going to go? And this depends on the level of access that you would like to provide the allied healthcare professional, or in this case, pharmacist. Do you give them read-only access, or do you give them read-write access? And so referral information, again, if they have read-only access or read-write, they can go into your chart, gather the information that they need to help manage the patient's problems and their main reasons for referral. So they have access to that information, but if you are looking for an updated medication list, update on perhaps their medication preferences, their beliefs, their willingness to take another medication to manage their condition, their payment plans or concerns that they might have around payment or other support, or even special authority forms that need to be completed, pharmacists are able to contribute to that and manage the patients that are referred. Other sort of more advanced, once that sort of team functioning has sort of landed and there's a bit of more of that trust that's being built, there is an opportunity for pharmacists to be able to take verbal orders, whether it be prescriptions or labs, for the care that you have agreed upon, a management plan with that particular patient. They can write their encounter notes, or they can upload their own consult notes into wherever you want it to go within the EMR. Within the messaging component, really sort of just highlighting that opportunity to collaborate very quickly, very efficiently. Hey, I've got this question. This is the patient's record. Here's the you've attached it to a message or a tickler, and they're able to take a look and perhaps respond to you quite quickly. So it's really just highlighting that read-write access really helps facilitate a lot of different elements within the care of these patients. To talk a little bit about what that looks like from our experience is, well, we can put our notes, the pharmacist consult notes, into the encounter note, or described as our toilet paper roll. It's easy to find. If there's a more complex sort of consultation note that goes in, it's possible that it might get lost in additional follow-ups as it's a little bit further up and might have to load. So there's sort of advantages and disadvantages for that. Otherwise, similar to other consult notes, it can be uploaded as a document into the documents module, and it's very similar to the ways that you would perhaps be familiar with seeing other consults from other healthcare providers. Sometimes when there's more longer, more detailed notes, maybe a titration plan, a cross-tapering plan, a tapering plan overall, is that these are perhaps a little bit more easier to find instead of in an encounter note, but again, would depend on patient to patient and also your own preferences for your own workflow. It does require some additional clicks, another window pops up, but again, pros and cons. But again, really just to highlight the opportunity for updated data. So medication lists, patient preferences, special authority forms, and being able to facilitate the care of your patients. But there's a few other things. So we've gone through sort of those 3 milestones. So you have pharmacist who has EMR access, you've identified the patients, they've seen the patients, you're collaborating, you're working together, you're managing the patient's conditions. There are some things that we have come across that have been some barriers, but we don't necessarily have solutions, but they're just problems that we have sort of come to encounter. Messaging, inbox ticklers, great if you are not co-located, but there is this threat that you're not seeing each other face to face anymore. You don't have that human to human interaction. So the trust that develops within that team may take longer to develop. And so there's some cautions that are there. Some of the solutions that we've sort of addressed or done to work around some of this is co-located models wherever possible, but case conferencing as well. Even if it's just through the phone, there's at least that human-to-human contact rather than through the OSCAR EMR or other messaging systems. As part of that team functioning element, the jargon that you use, the elements that you want to be included within your chart note there will be a bit of a learning curve. As more healthcare professionals may have access to your EMR, you just want to make sure that you're using the same language. And that is just part of the storming process of the development of the team. The other consideration that we've come across in the literature, we haven't come across this necessarily in our practice that we've seen explicitly, is that there is this element that providers don't trust others to have captured all the information that they would have during a consult. And this just, again, really, I think, emphasizes the opportunity for shared information. You've gathered parts of that information. Physician has gathered some, pharmacist has gathered some, maybe a nurse or a mental health counselor or a physiotherapist may have gathered some, but it's all in one place. And not all health professions are able to upload to a place like Care Connect to have that accessible by everyone. So it's just putting all of those pieces of the puzzle together, again, to help support the care of the patient. So what we have seen as part of what we would call best practice, or a practice perhaps, is that EMR access, what we have found most successful for collaboration purposes is read-write access. When generating referrals, use both approaches wherever possible. The prescriber will have those people who are top of mind. Pharmacists can do a more data-driven approach as they get to know your own patient panel. And then coordinating care is just so flexible of how, based on your needs and your preferences, that there is that opportunity to work together. So that's been our experience. We've got a whole bunch of references that we can share with you if you do have any questions, but you can also contact us by the emails there if you are interested in, I guess, pharmacists and getting involved in your practice, and maybe we can help facilitate some of that. But we'll open the floor to questions or your own experiences collaborating. We've got one in the back there. Yes.
And those need to be deleted, or alternatively, that computer needs to be secure.
Yeah. I think, does that fall under the team charting agreements at all?
I think so, but also like all of our pharmacists, like I can only speak for the ones who ours work under, they're technically health authority employees. Right now they're going into OSCAR and our OSCAR instances under VPN. Most of the time, but they also can access under their health authority, which again is VPN. It's not a private computer. So I think that does add a layer of security because those systems are secure. They're not open to the public. So I hope that that would be something that would mitigate that risk.
Mm-hmm.
After you shut the program down, the information is still on the computer in many cases.
Mm-hmm.
Yeah, it could exist exactly in your download folder, and that would be poor practice. Absolutely. I think for any healthcare professional, that's going to be poor practice. That's part, I think, of the team charting agreement, part of the standards of information privacy for patients as well. If they're not following that, or if any healthcare professional is not following that, then there should be penalties to that. But for sure, I think that the risk can be mitigated through some of the team charting agreements that you would have with the pharmacist, and also some of the policies and procedures, as most of them, the vast majority, are from our health authority employees. So there are those standards that must be followed. Shan.
Do you have a thing called MedCheck?
MedCheck. Not
In
familiar.
Ontario, it's one of those great ideas, meaning the pharmacist basically would do a consult without even the family doctor's agreement.
Yeah.
And then they send you this great thick report that most family doctors kind of say, okay, I can have to.
Right. Yes.
You know, when you make something, do I have to respond? Do I?
Yeah.
Right?
What do I need to do with this? Yeah.
It's a very bad idea. And it's, you know, this is talking about spending, the
Yeah.
government spending all these millions of dollars. Then we were there to try to evaluate these good or bad. I mean, it should be the other way around. Or it should be at the very least in the beginning to incorporate evaluation being part of the program.
Yeah.
The second thing, just to comment, we work with pharmacists for so long, and it's just a delight. It's just wonderful. One of them is their involvement with the K2A, the Northwest.
Yes.
Is that, you know, they're the one who are actually following all the latest health Canada stuff. And they send out little quick warnings, or if someone else beat them to it, they will give you comment about, you know, that this is, you can try this or that. And another one would be, they do quality assurance, you know, the idea, for an example, Hardy Farms. They select from their clinic, you know, all the people that have more than 5 drugs.
Yeah.
You know,
Yeah.
of certain types, and then they go through it, and they provide a lot of insight and suggestion. And lastly, one of our Internet of Thing project was this e-docent. We actually camera tape the time that the patient take their and 1 out of 10. When they say the morning pill, they take it at 2 a.m.
Oh yeah. Absolutely. Yeah.
To the extent the pharmacist would be involved, sitting down and trying to simplify the way we prescribe, all kinds of really useful things.
Yeah, for sure.
Yeah. Yeah, I think the equivalent program in BC that you're talking about is a medication review done by community pharmacists. So, you know, some depending again whether they have EMR access, and that's I think why it is really beneficial if they have a bit more of the picture, because again you're the keeper of the information of why are they on this medication. You know, you probably have somewhere in your chart, unless you inherited that patient recently and they came on 20 meds, and you haven't had a chance to dig into every reason for every medication. And that's where it can be helpful, like you say, with a polypharmacy patient. And we might, you know, we tend to focus more on like 10 or 15 or more meds because, you know, 5 or more meds is probably almost all of your patients, right? But for sure, like that is definitely a role. And we typically try to, you know, most of the time in most of our PCNs, there's maybe a few where a patient can self-refer. But for the most part, it's either a referral from a provider, from another healthcare worker. So it could be the dietitian sees the patient, sees they're on a lot of medications, they've got diabetes, they think the pharmacist could be beneficial. You know, a hospital provider, you know, a hospital pharmacist or hospitalist that sees the patient being discharged and goes, whoa, there are lots of med issues. Maybe the PCN pharmacist can be helpful. So they're typically had been somewhat referral based or like working with your practice. However, there are times when a patient might be like, oh my gosh, I'm having all these side effects. I really need some help, right? And so they, you know, it might make sense for a self-referral. But we are, like all of our pharmacists are salaried, so yeah, we're done, I think. Yeah, so there's no like financial whatever.
All right. Well, thank you all very much for your time and attention.